Okay, let's dive right into this. Welcome to The Explainer. Today, we are unpacking a really fascinating, highly debated, and incredibly timely policy question. We're asking, should a nation unlock its citizens' compulsory medical savings to fund elective fertility treatments? Specifically, we're going to examine the situation unfolding in Singapore right now, and we'll be looking at it through the analytical lens of Dr. Alexis Heng Boon Chin. It is this massive collision of demographic panic, cutting-edge reproductive technology, and the strict, unforgiving economics of national healthcare. To really understand why this debate is happening right at this moment, you have to look at this startling number, 0.87. As of 2025, that is Singapore's total fertility rate. It is an alarming, historic low. Now, to put that into perspective, a population needs a replacement rate of about 2.1 just to remain completely stable. The math on that is actually pretty straightforward. Basically, you need 2 children to replace 2 parents, plus that extra 0.1 to account for natural mortality rates. So sitting at 0.87, Singapore is literally producing less than half the babies needed just to replace its current population. We are talking about an existential demographic crisis here, one that has everyone desperately looking for immediate solutions. Here is our roadmap for this explainer. 1. Singapore's demographic crisis. 2. The purpose of MediSave. 3. Elective egg freezing risks. 4. Unproven benefits of PGT-A. And finally, 5. Real socioeconomic solutions. Section 1. Singapore's demographic crisis. When a country's birth rate plummets this dramatically, it doesn't just mean we have fewer kids in elementary schools, it alters the entire fabric of society. The economic and social fallout of that 0.87 fertility rate is just staggering. Think about it. A shrinking workforce means fewer people out there driving the economy and paying the taxes that keep things running. At the exact same time, Singaporean women currently have one of the highest life expectancies in the entire world, sitting at 86.1 years. Imagine a seesaw. On one end, you have this massive aging population, and on the other end, a rapidly shrinking base of young workers who are trying to balance all that weight. It creates an almost unbearable strain on social support systems. So the stakes for the nation's future absolutely could not be higher. In the face of this existential challenge, a really loud chorus of voices has emerged with what seems at first glance like a very intuitive proposal. People are asking, if society desperately needs more babies, shouldn't the government allow citizens to unlock their mandatory national savings to fund assisted reproductive technologies? Specifically, a lot of the spotlight has been put on elective egg freezing and a genetic screening tool called PGT-A. It sounds incredibly logical, right? If the tech exists to help people start families, why on earth wouldn't we use the funds available? But according to Dr. Heng's analysis, the short answer to this proposal is a resounding no. Section 2. The purpose of MediSave. So the crucial point is understanding the actual mechanics of the financial safety net we are talking about here. In Singapore, citizens subscribe to the Central Provident Fund, and the specific medical component of that is known as MediSave. It was established back in 1984. Now, it is absolutely vital to understand that MediSave is not some bottomless pit of general government subsidies. It's a mandatory personal savings account. The key phrase you really want to focus on here is deferred income. It is the citizen's own future survival fund. It's locked away specifically to ensure they do not go bankrupt when they inevitably face major, life-threatening medical bills later down the line in their exceptionally long lives. Because of that incredibly critical role, MediSave operates on 3 totally non-negotiable principles. First, medical necessity. It is designed to treat existing illnesses, not to fund lifestyle choices. Second, financial sustainability. The system has to make sure individuals simply don't run out of money when they are old and sick. And third, evidence-based clinical effectiveness. Basically, it demands hard, undeniable clinical proof that a medical procedure actually works before the financial tap is opened. These 3 principles act as a strict gold standard for public health funding. And when we test the proposed fertility technologies against this rubric, Dr. Heng's analysis concludes that they ultimately fall way short. Section 3. Elective egg freezing risks. Now, in 2023, Singapore actually legalized elective egg freezing for women aged 21 to 37. It was officially recognized as a valid option for reproductive autonomy. But the Ministry of Health drew a very firm line in the sand. Absolutely no MediSave funding for it. Notice the core ethical distinction Dr. Heng draws here between a medical procedure and an elective one. On one hand, you have medical egg freezing. This is where a woman freezes her eggs before she has to undergo something severe like chemotherapy. That is a crystal clear medical necessity, responding to an involuntary illness. MediSave covers that. Elective egg freezing, however, is often a social choice. It's used to mitigate the natural decline of fertility, frequently so someone can pursue career goals or personal milestones. Dr. Heng highlights that this is an elective decision. It's not a treatment for a disease. His argument is that if you open up national medical funds for this, you could easily pave the way for funding all sorts of other purely elective procedures. Then we have to look at financial sustainability. Elective egg freezing is exorbitantly expensive. We are talking between 10,000 and 15,000 Singapore dollars per cycle. Pop culture often treats egg freezing like it's this guaranteed insurance policy, right? Like a foolproof way to just hit pause on the biological clock. But the clinical reality is actually quite different. The pregnancy success rate per frozen egg is remarkably low. According to the American Society of Reproductive Medicine, it sits around 2 to 12%. Because of those odds, many women end up requiring multiple, wildly expensive cycles. The author cautions that allowing young women to drain their MediSave accounts for this specific procedure risks leaving them entirely financially exposed decades later, right when real, life-or-death medical contingencies actually strike. And this brilliantly illustrates perhaps the biggest financial risk of all. A 2021 Australian study looked at over 4,000 women who stored frozen eggs in Victoria, Australia. The findings were pretty shocking. Less than 4% of those women ever came back to actually use their eggs. Let that sink in. 96% just sit there unused. From a national savings perspective, Dr. Heng argues that unlocking MediSave for this would mean subsidizing a massive sunk cost with funds that were expressly meant to secure a citizen's old age pension. It's a huge financial gamble. Beyond just the financials, the clinical realities of the procedure are pretty harsh. The simple fact is, frozen eggs have lower success rates than fresh ones. Plus, the extraction surgery itself carries very real risks, like ovarian hyperstimulation syndrome. Furthermore, the author points out a major policy contradiction here. He argues that subsidizing this actually creates a moral hazard. Think about it. A state-funded technological safety net inadvertently signals to society that it's perfectly fine, maybe even encouraged, to delay parenthood. But biological reality remains totally unforgiving, and older pregnancies actually place even higher strains on the broader public health system. Section 4. Unproven benefits of PGT-A. So, this brings us to the second technology that advocates desperately want funded by national savings. PGT-A. That stands for Pre-Implantation Genetic Testing for Aneuploidies. In simple terms, it's a procedure used during IVF to screen embryos for abnormal numbers of chromosomes. The goal is to detect issues like Down syndrome, particularly in older mothers. Now, to be clear, MediSave already covers targeted genetic testing if a patient has a severe specific family disease, like Huntington's. But PGT-A is a different beast entirely. It's a general, broad screening tool that gets applied to all embryos across the board. The primary argument against funding PGT-A comes right down to that third MediSave principle we talked about, evidence-based effectiveness. The source material explicitly states this, and I'll just quote it directly. Several large-scale, multi-center clinical trials found no significant difference in ongoing pregnancy rates between patients who used PGT-A and those who didn't. That is a completely crucial finding. If a procedure cannot prove, through rigorous, undeniable data, that it broadly improves actual live birth rates, the author argues it simply has no business whatsoever being funded by a compulsory medical savings account. In fact, routine PGT-A carries inherent clinical risks that can actually lower a couple's chances of having a child. It's a three-step problem. Step 1, the biopsy process to extract cells can physically damage the embryo itself. Step 2, the test is highly prone to false positives due to a fascinating phenomenon called rosaism. This is a situation where an embryo has both normal and abnormal cells, but the amazing thing is it could naturally self-correct as it grows. But because of this, we get to step 3. Perfectly viable embryos are unnecessarily discarded based on a flawed test result. Just imagine the human element of this. A couple goes through the incredibly costly, emotional, and taxing process of IVF, only to discard an embryo that could have resulted in a totally healthy baby purely due to a false positive. Dr. Heng also raises some really serious ethical boundaries regarding this tech. He argues that the routine funding of PGT-A edges uncomfortably close to the commodification of human embryos. It risks treating them almost like products on a manufacturing line that are subject to strict quality control. The source also notes it opens a dangerous door to potential misuse, specifically the risk of social gender selection. And just for context, gender selection is a practice that is strictly banned in Singapore. Section 5, Real Socioeconomic Solutions. Let's move to and see how this builds into actual policy changes. If these technological shortcuts aren't the answer, then how on earth do we fix the fertility rate? Well, Dr. Heng argues that Singapore's demographic crisis simply cannot be solved by raiding retirement healthcare funds. The root causes of low fertility aren't biological at all. They are fundamentally socioeconomic. So instead of relying on what he calls Petri dish gambles, he suggests the government needs to implement heavy, upstream, structural interventions. He argues that society has to replace the demand for elective egg freezing with a workplace culture that truly, genuinely embraces flexible arrangements. He points to the desperate need for radically affordable childcare and aggressive pro-family housing policies. The goal is to make citizens feel secure enough to start families earlier in the real world, rather than feeling forced to delay parenthood through clinical means. To support all of this, the analysis calls for a really aggressive public education campaign. The author argues it is absolutely vital to combat the widespread misconceptions that are driving the demand for these elective procedures in the first place. People need to clearly understand the unforgiving nature of the biological clock and the realistically low success rates of assisted reproductive technologies. Additionally, Dr. Heng stresses that there needs to be much stricter oversight of private fertility clinics. This is crucial to ensure that vulnerable patients aren't being sold false hope through overly aggressive profit-driven marketing tactics. The core takeaway from Dr. Heng's analysis is incredibly clear. Elective egg freezing and PGT-A absolutely have their place in the landscape of private reproductive choices, but that place must remain privately funded. He argues that the integrity of the MediSave scheme was built as a collective shield against the crushing costs of essential healthcare in old age. From his perspective, that sacred trust must be vehemently protected. It cannot be drained for what he views as commercially driven lifestyle choices that lack broad, proven clinical benefit. And that leaves us with a final, highly provocative thought drawn directly from the heart of this policy debate. It highlights a really perilous, slippery slope in healthcare economics. If governments bend their own rules and allow mandatory retirement health savings to fund elective lifestyle choices today, what exactly will they be asked to fund tomorrow? Thank you so much for joining us for this explainer. Keep questioning the details behind the policies, and we'll see you next time.